please, you might have to leave because we're going to record it. This is ITPC's Roundtable, looking at COVID-19 testing, pricing, and community-led monitoring. We have quite a number of questions that were taken from persons writing into the admin at ITPC email, and we will use that as we move along to go through the process and also take questions from you live as you type it in. This is a webinar, so there is a function box that is a chat box, and then there's the question and answer. So we'll be using the question and answer box. Just because we really need to these days, due to the fact that there's been quite a bit of Zoom bombing, I guess you'd call it, is a code of conduct and just assumption that all people who are joining as meeting participants of this Zoom, that you will agree to act fairly and in good faith and with respect. Otherwise, we may have to remove you. Just need to say that. So the plan for the next 2 hours, I will open. My name is Solange Baptiste. I'm the Executive Director at ITPC. So I will open and give a couple of framing comments, and then we'll move to listening to our speakers. And we want to thank each one of them for joining us, and for you for joining us as well. We will introduce them. We'll ask them to give about 5 minutes of perspectives from their side. They're all professionals and experts in their field. Then we'll have a round of discussion among the featured speakers, and then we'll try to hear from you if you have any questions, comments. We'll be looking at the chat box, but primarily using the question and answer box function of Zoom, and we'll indicate when you should start typing your questions in the Q&A box. But look, it's ITPC, so we're not that formal. If you need to chat and you need to write something, please do so in the chat box. But if it's a really pointed question that you may get a written answer for, please put it in the Q&A box. But we'll also be trying to pick up key themes and questions and putting it into there. And then we'll do a summary and close. So as our panelists are introduced, we'll ask them to turn on their microphones and their videos. Not everyone will have great bandwidth, so we want to make sure we manage that as needed. So just starting with some opening comments. COVID-19 has really changed the world. No one has expected that in 2020 this is where we would be. However, we have a rapidly changing environment. When you think you've gotten a hold of, okay, this is what it is, this is what coronavirus disease looks like, and these are the therapeutics, and kind of walking with the story and the journey, something changes. And there's a lot of misinformation and confusion, and quite a bit of the information coming particularly to communities has not been connecting. And so we are, as ITPC, oftentimes trying to debunk and demystify and correct quite a bit of misinformation that is out there. The experience of communities during COVID-19 is something that not only ITPC, but many of our partners have been working on trying to capture and see how we can intervene to mitigate the stress. It moves from anger to like, we can't do anything, which is like paralysis, to amazing innovations within communities, of course, fatigue, because it's just so much to deal with now, the stress, but then glimmers of hope, issues of food insecurity, loss of wages, secondary illnesses as a result of COVID and people not coming to clinics, and quite a bit of fear. The concerns we have are not only just on this lockdown and saying, okay, well, lockdown, and how long is lockdown, and what kind of lockdown, and when will it end, but the levels of preparedness for what we would have to consider as the new normal going forward after this acute phase of the disease. Some of the concerns and challenges we've also brought up from communities have been around the breakdown in primary health care. So countries with already weak and fragile health systems, particularly primary health care, will see a wave of secondary issues and illnesses due to COVID-19, whether it's unwanted pregnancies, requests for terminations of those pregnancies, untreated diabetes, untreated hypertension, issues with TB, and access to basic primary health care. And we are looking at what those innovations should be. Obviously, there are issues around access to testing and the usual concern around, well, are we going to be begging and can we even afford the medicine when it comes out and the vaccine? The experience of the PPE, for example, not being able to get basic things like masks and clean water, what is going to happen? And it's a real concern that people have with respect to therapeutics and vaccines. So, I mean, in our previous roundtable, we heard from community voices on COVID-19 and HIV, and really focusing on the household and communities in particular, not just governments and manufacturers and industry, but communities being the anchor and the source of resilience and care, but they have to be supported. There are people running all over trying to make sure that people get their medicines without any support, literally job loss, particularly those who are key and affected populations in the HIV space, and really wanting to use this space and this time now to think about what we should be demanding as communities, looking at what we should demand now. So we're hoping that this asking for a friend allows us to have a safe space where you can ask any question you like, and once our panelists can answer it, or even our attendees, because obviously we are not the whole world of those who are working in the space, should be able to answer some of these questions, and we will try to use the time wisely. So that's about 7 minutes. As a reminder, this is a webinar, so you will not be able to unmute yourself. So if you need to make a comment, please do so in the chat box, and then obviously use the Q&A for specific questions. I am just going to walk through how we'll use our time. I already did that, so I'm going to hand over now to my co-moderator, who is Wame Jallo. She's the Director of Global Programs and Advocacy at ITPC, to introduce our featured speakers, and I will jump right in. Thanks, guys.
Thank you, Solange. Welcome, everyone. Good afternoon, good morning. We have a really great lineup of speakers today to cover all our topics: testing, pricing, and community-led monitoring. First on our list is Lara Vojnov. She is the Diagnostics Advisor for HIV and Hepatitis C and COVID at the WHO, the World Health Organization. And she was recently seconded to the emergency response for COVID from a diagnostics perspective. Also with us is Vincent Bretin from Unitaid. He is the Director of Results and also the Coordinator on Access to COVID-19 Tools Act, the Accelerated Diagnostics, which is a recent initiative of Unitaid. With us as well is Andrew Hill. He's a medical doctor and senior visiting research fellow from the Liverpool University in the United Kingdom. He's conducted quite extensive research on treatment optimization and access in developing countries. We have Mr. Othoman Mellouk, who is the access to the intellectual property and access to medicine lead at ITPC, and he leads on our work around the Make Medicines Affordable campaign, promoting access to medicine in middle-income countries. We have Lotti Rutter from Health Gap, and she is the Associate Director of International Policy and Advocacy at Health Gap, based in South Africa, working extensively with the Treatment Action Campaign on the Richise project, which monitors quality of services in clinics across South Africa. We have joined...
Sorry, Lotti, you want to say hi, like, yes.
Thanks, Lotti. We have Alain Mumba from EANNASO. She is the Executive Director and has worked extensively within the civil society context, strengthening engagement and participation in global fund platforms, as well as frameworks. And Alain, who is the Community Monitoring Lead at ITPC, leading on all of our Watch What Matters campaign, which is facilitating and implementing community treatment observatory and community-led research. So a really warm welcome to all of our panelists. We're excited for the next 2 hours to get a lot of information that we've all been seeking for. So to get us started on the topic of testing, Lara, can I invite you to share with us some of the reflections, and then we'll move on to Vincent. So Lara, over to you.
Lara, also sharing your face, yes. Yay.
No, I'm fine. Good afternoon or good morning, everyone. I just want to thank ITPC very much for inviting me to join this really exciting panel. So as mentioned, I've been now seconded to the health emergencies team here at the WHO for my previous work within HIV. Trying to still wear both hats and continue to be supportive for HIV and hepatitis while I try and support the work on a very challenging, and as Solange says, a very changing dynamic, and that's very much the case on the testing side as well. I'm sure you've heard a lot of the interesting and ever-changing aspects within the testing strategy and testing approaches on the news quite regularly around what different tests might mean, whether we should get tested, who should get tested, et cetera. And it's been quite a complicated piece because it is quite different from the HIV standpoint. Right now, at least, we primarily suggest patients get testing using molecular technologies, which is very similar to the tests that you would do for HIV viral load, for example, and that would be in order to try and diagnose patients. At this stage, it's a little bit challenging and complicated to be thinking about COVID antibody tests, and that's for several different reasons. Of course, those would be ideal if we'd be able to get them and use them, and depending on their performance, but some key challenges exist with those antibody tests. In particular, it's hard to know whether you're currently infected if you have antibodies or were just previously infected. And so identifying patients right now who may need care is something that is challenging with that type of a test. Furthermore, it's clear that while it's not yet clear whether patients who have antibodies maintain them for a long period of time. We have seen some patients who lose their antibody response over time. Some people don't even build an antibody response. And then, so I think, in that regard, and then of course, we also don't know that if you have antibodies, if it actually prevents you from being infected again at a later time point. These are some of the key basic science principles that we're really trying to better understand because, and primarily, it would be ideal to be able to use one of these tests, whether it's an antibody-based test where you can just use blood and it's very similar to an HIV rapid test, or even an antigen-based rapid test would be nice as well, because they're much simpler and we could gain far more access to the testing market. Because one of the biggest challenges that we have seen is that because of it is a global pandemic, nearly every country is now affected and is seeking access to different diagnostic tests. The access to testing in low and middle income countries in particular has been really relatively behind those high income countries who are able to pay and can afford the higher prices in their settings. And so opening up that market to additional tests is something we're looking at, but still don't yet have confidence in the ability of those tests to be able to biologically identify what we need them to identify. And then, of course, similar to other areas such as in HIV, the performance of those tests needs to improve in order to see that confidence. But in the meantime, we do have these molecular tests that we have used quite a bit in the HIV and TB spaces. We're still trying to seek better access to these tests. And here at the WHO, in collaboration with a number of partners, including Vincent and Unitaid's team, who's also here, we've tried to set up a Diagnostics Consortium, and that includes other key procurement agencies like the Global Fund and UNICEF, as well as technical partners, to work with suppliers to increase the access to low and middle income countries, to potentially and ideally eventually reduce prices for tests across all of the different test types, and provide as much information as we can to countries in order to move forward with their testing needs in terms of some of the operational considerations. This consortium's moved forward now over the last few weeks, and we're hoping to start seeing some tests being provided, at the very least, some minimum access items for a number of countries. And actually these consortium, and Solange, you touched on the issues around PPE as well. And we also have some access challenges to oxygen and clinical management commodities. And we've now developed separate consortia for both of those different commodity areas in order to try and expand access. So perhaps I may stop there, and if there are any questions, I'm happy to respond.
Great, thank you very much, Lara. Just to remind everyone that we will have a Q&A session at the end of all the presentations. So please utilize the Q&A box at the bottom to write up any questions for discussion needed. Thank you very much, Lara. Vincent, can I give you the floor to also provide some insights on testing as well?
Sure, thank you, Wame, and thank you very much, ITPC, for the opportunity to speak on behalf of Unitaid. And I speak actually from the standpoint of Unitaid, but also from the standpoint of the ACT accelerator in diagnostic, where quite a lot of discussions are happening as we speak. So the first point I wanted to touch is the need in terms of testing across the world. Lara talked about a number of types of tests that are either available today or would be available, we hope, soon. But in terms of number of tests that we would need, there's been some recent estimates that are suggesting that over the next 12 months, it's about 500 million, 500 million tests that we would need across low and middle income countries. And that's covering a population of 5 billion people really around the world. And there's a mix of those tests, of course, between molecular tests, which are the ones that are available now, but more expensive, more difficult to use, coming with logistical challenges as well. And the rapid tests, which would be obviously easier to use. So just to give a sense of this magnitude, I mean, this is comparable in size to what the level of testing that's happening in HIV. So we're talking about setting up in the next few weeks and months, a testing intensity that is similar to what is existing in HIV. There's a number of specific challenges here, of course. First one is that the tests are not available. Not all of them are ready yet. They need to be developed. They need to be evaluated in terms of performance. And that is work that is happening and will need to continue to happen. We need to define how to use them. Lara talked about some of the questions that are still here. Can we use, for instance, an antibody test to provide an immunity passport to people? At this point, we cannot say that we can do that. So a number of questions around what would be the use case, how each type of test can be used given the specific needs of different countries. Questions around production capacity. We have a number of manufacturers, actually a wealth of manufacturers coming with tests. Some of them have large production capacity, some much more modest production capacity. We need to find solutions, for instance, to help smaller companies increase their production capacity, or to do technology transfers and do things that don't happen by themselves, but where we will transfer the technology from one company to the other to really increase the volumes of tests that we can do. We need to work on prices. The prices are still relatively high. And if you compare to HIV, for instance, both the molecular testing for COVID are more expensive than what we see in HIV or TB. But also the rapid tests that are coming to market are much more expensive than the typical prices we're used to see for RDTs. So we need to work with manufacturers, with all the partners to find solutions to reduce prices. There are things to do, for instance, on raw materials. There's been quite an increase in prices of certain raw materials that are used in making the test, and we need to work on reducing those prices. There will be also questions around allocation. And Lara alluded to this. Right now there's a need that is huge, that is across countries. There is a bargaining power, obviously, that is extremely unbalanced across countries in the world, and all countries want tests today. We're seeing it on the tests that are available today, that this bargaining power is really coming into play very strongly. And so there needs to be mechanisms like the one Lara mentioned, the procurement consortium, to look at the need and to establish in a fair manner how to best allocate and distribute the available tests. And this is one element that is taken forward by ACTA. And finally, there is, of course, quite a lot of work that needs to happen in the countries themselves to prepare, from an operational standpoint, the countries to implement those tests. So that's the kind of work that is ongoing, within the ACT Accelerator. This is an initiative that was launched in particular with the leadership of the European Commission, a number of countries, but also a number of partners like WHO, Unitaid, Global Fund, and others, which aims to, at the same time, mutualize and mobilize resources for the COVID response from a number of donor countries with very ambitious resource mobilization objectives of 7.5 billion euros. But also an unprecedented effort to coordinate the response for vaccines, for treatments, and for diagnostics. So that's something that is being set up as we speak. Civil society has definitely a seat at the table in all of those discussions across vaccines, therapeutics, and diagnostics. And we look forward to, in the coming weeks, first of all, securing the funding to do all this work and doing it, of course. Happy to take questions later, and I'll stop here.
Thank you very much, Vincent, for that, and to Lara. We heard a lot of really important comments and reflections around considerations on scaling up testing, the pricing, the production capacity, the volumes needed, etc. We'll have a chance to open it up for Q&A at the end. I would like to move to the next topic, which is around pricing of not only medicine, not only the treatment, but also looking at the issues and as well as access issues as we move forward with COVID response. So inviting Andrew Hill to provide us some information about the latest research on pricing and some reflections. Thanks, Andy.
Thanks very much. Okay, thanks for putting up the slides. So we published this analysis in the Journal of Virus Eradication in early April. And basically, if you look at HIV and hepatitis and tuberculosis and malaria, the drugs are available for most people in low and middle income countries at prices very close to the cost of production. So what we tried to do with COVID-19 is look at all the drugs that are being developed and try and see how cheaply you could make them based on cost of production. Could you actually treat the world for coronavirus for low prices? Next slide. So basically, without a vaccine, we need drugs now. We need repurposed treatments from other diseases. There are drugs that are normally used to treat HIV, hepatitis, influenza, malaria, and they're being repurposed. People are seeing if they work against coronavirus instead. What we really want is an oral dosing drug rather than IV and intravenous drug, much easier to use. We need drugs that are already available on the market, generic, mass-produced, lots of factories already producing them. And ideally, we'd want a drug which worked both for prevention and for treatment. It might be that we need 2 or 3 drugs in a combination to treat coronavirus effectively, just as we use 2 or 3 drugs to treat either malaria or hepatitis C or HIV. Next slide. So what in my research team, we have access to databases looking at all the raw materials for drugs and where they move around the world, the price of a kilogram of pretty much any drug you like. And once we know the price of a kilogram of a drug, we can work out how much it costs for the few grams for an individual's treatment course. We can add on extra amounts for packaging, for transport, taxation, formulation, very well-established formulae which work with other treatments to calculate how much these drugs cost to make. The next slide. So just one example, this is a treatment, sofosbuvir declatosphere. It's being tested in 8 different clinical trials in Iran, a large clinical trial in Egypt. It's being started in South Africa and Uruguay. It's very early days. We don't know if it's necessarily going to work, but that's true for most of these repurposed treatments. But just to give you an idea about what's at stake here, if you wanted to treat somebody for coronavirus with sofosbuvir declatosphere, that treatment could cost $7 in India, $6 in Pakistan. It costs $5 to make. But that same treatment in the United States could cost $18,610. In the UK, $7,600. Even Brazil, $4,300. So you can see here how if these drugs work, we need to make sure that they're available for anybody in any country at prices close to the cost of production. Otherwise, we might have effective treatments and countries are simply priced out, they cannot access them. Next slide. We've looked at this for lots of different drugs, and you can see a pattern where really on the right-hand side, estimated cost price, you could treat coronavirus with these repurposed treatments for very low unit prices for almost all of them. And actually, most of those drugs are already available in India or Bangladesh or China for prices quite close to the cost of production. Some exceptions like favipiravir, pirfenidone, but there is the potential already to do this if these drugs work. And we've got to remember, this is a big if. A lot of these drugs are still in the middle of clinical trials, and there was a setback with hydroxychloroquine last week. So we need to just be a little bit careful. But with 10 drugs in development, I'd be surprised if they all didn't work. I think we're going to find one or two that work, and that's really what we need. Next slide. So why should we be giving people drugs at close to cost price? Well, you think about the development programs, most of the money that's been used to develop these drugs has not come from the pharmaceutical industry. It's come from the Gates Foundation, the National Institutes of Health, from donors, from national health authorities in all over the world. And even when the companies donate drugs for the trials, most drug companies actually make a profit when they donate drugs because they're given a tax rebate and they're not actually spending money. And remember, these drugs are just working by accident. This virus is brand new, and we're bringing in these drugs from other diseases. So there's very little R&D money that's been spent so far. Next slide. So just to sort of conclude, we believe that if these drugs work, you could treat coronavirus in any country for approximately $1 per day, and often much less than that. These treatments could be mass produced so that anybody with coronavirus in any country could afford them. And remember, we already have a mechanism for mass treatment of HIV, TB, malaria, with drugs sold to 20 million people with HIV at prices close to the cost of production. Next slide. So the next step really is to start thinking about what would we do. Imagine favipiravir was proven to work against COVID-19. What would we do if sofosbuvir clatosphere worked? We'll know the results from these studies from phase 2 quite quickly. We'll need to wait for phase 3 for some of the drugs into August, September, but we'll actually know very, very soon. But we need to start alerting the generic manufacturers, getting supply forecasts, and seeing how easily we could upscale these treatments so that everybody in any country has access to them at these very low prices of $1 a day or less. Okay, thanks.
Thank you very much, Andrew. Always very informative. In addition to looking at pricing, we need to look at issues around access. So inviting Othoman and Mellouk to provide some context around what are the considerations for scaling up access. Othoman? There you go.
Oh, okay, sorry. Good morning, good afternoon, good evening, everybody. Thank you, Wame. I think to discuss the issue around access and around intellectual property, it's very useful to remind these algorithms. So we know that if we have a patent, we have one supplier, there is no competition, and of course the supplier can decide whatever price they want, and we have very often very high prices of imported medicines. When there is no patent for different reasons, and I will come back to this later, we have multiple producers, we have competition, and we have low-cost generic medicines. From the Make Medicine Affordable campaign, we think that patents should not be a barrier for access to any medicines in the context of COVID-19 pandemic. And the any is very important, and I insist on that, because it's not only about a potential COVID-19 cure or treatment, it is also about other medicines, and we see that there is problems of shortages of access to several medicines that are needed. And I think this is very important. And this has already planned in all the different regulations and laws that exist either at national level or at international level. Next slide, please. So, as Andrew said, most of the medicines that have, we know coronaviruses since a while, probably not this one, but others, but there has been no investment in R&D for pharma, otherwise we would have had the treatment now. And most of the medicines that are being tested today are old medicines that have a kind of potential activity against coronavirus. But this has been discovered by accident, as Andrew said, and there has been no effort in research and development to find a cure or treatment for COVID. And let's be clear, the TRIPS agreement allows countries to exclude discoveries from patents and request novelty. First, these drugs are not new, these are old drugs, and there have been no invasive steps that can justify granting patents on these medicines, at least for the treatment of COVID. We discovered by coincidence that these medicines that have been developed for Ebola, for hepatitis C, for other drugs or whatever, that they may have some kind of activities. And as Andrew also said, most clinical trials are conducted today with public funding and support of countries. More than that, communities are paying from their lives. There are people who are under this treatment and being tested, and some of them unfortunately are dying, and they are contributing to the efforts of the science, etc., to prove whether these medicines are effective or not. Next slide, please. So there has been a lot of discussions recently whether yes, but pharmaceutical companies are responsible, they are coming with deals, with solutions, and we should trust them or whatever. So the real question is really, what's old? Is it new again? I personally, and from the campaign perspective, and I'm not speaking about myself, I'm speaking about the whole consortium that with people coming working in 17 middle-income countries and who are working on this, we don't think that what's old is new again. And I'm speaking here about the voluntary mechanism discussions. So this is an exceptional situation. We are not in a situation of low and middle income countries dealing with a situation or whatever. Specific populations, people who inject drugs, sex workers, MSM or whatever. This is all countries are affected today by the pandemic. Budgets all over the world, from the rich to the poor, are stretched, whether health budgets or even general budgets, because we have all the economic impacts or whatever on the countries that we are dealing with. Everybody is at risk of COVID-19. We're not in a kind of specific populations or whatever. And we know so far that voluntary mechanisms have failed to solve access to several middle-income countries on HIV and hepatitis C. We have seen voluntary licenses on HIV, on hepatitis C, excluding countries like Brazil, like China, like regardless of the number of people who need treatment, etc. And it doesn't work for everybody. And we have seen abuse from pharmaceutical companies on the voluntary mechanisms and using voluntary mechanisms and licenses for PR. And I can give you the example of tenofovir. Today, if you speak to anybody, people will tell you, thanks to voluntary licenses, all Africa is switching to dolutegravir-based regimens thanks to voluntary licenses. I know that Viv is here on the call. So there are 5 patents that have been filed in Africa, in Egypt, in Kenya, Morocco, Algeria, and South Africa. Egypt, the patent has been rejected. So there is 4 patents. So today the reality is only Morocco, Kenya, and South Africa benefiting from a voluntary license on dolutegravir. All the others, they don't need a voluntary license because there is no patent on dolutegravir in these countries. And Algeria is still struggling because there is no patent, there is no license yet on Algeria, and Algeria cannot get access to generic. So pharmaceutical industries used this good model maybe of the medicine patent pool or other voluntary license mechanisms that may claim to increase access, etc. And we have all this in people's mind that it is thanks to voluntary licenses that we have access, blah, 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 etc. And what we see today is that the first voluntary license on a potential effective drug, well, I'm not going to enter into the detail to what extent it is effective, but the Gilead license on remdesivir is just disappointing. We have the same restriction of the geographical territory with some exceptions, with few countries included, but we have countries like China, like Italy, like Spain, like it's not anymore an issue of a rich or poor. Everybody is struggling, and I think this mechanism has some kind of limits, and this license, which opens the perspective for further licenses, is disappointing. The people who did this license, well, for now it's Gilead because there has been no implication of any public health institutions like the MPP or whatever. It's just if they were disconnected from the world and they are coming from with a model that didn't work for HIV, that didn't work for hepatitis C, at least for some middle-income countries and especially upper middle-income countries, and come in with a kind of old solution saying, you know, just trust pharmaceutical companies, we are going to solve the problem, and it's not going to work. And what we know from the experience is that voluntary mechanisms are more effective when there is a public pressures and threats from government. And we have seen this from licenses that have been improved by the past because there was the compulsory license in Malaysia, the advocacy activity, the extension of the dolutegravir license, etc. And we see that we need to have this kind of pressures. So I will end with this comment. So why don't we just adopt the same approach of the pharmaceutical industry? The industry is claiming that they have the right for market monopolies on the right basis approach because the TRIPS agreement and national intellectual property laws give them a right for a market monopoly because they invested on the research. But at the same time, if we look at the text, the same texts, the TRIPS agreements and the IP laws allows, while they allow granting monopolies, they allow strict patentability criteria. None of these medicines have been developed for treatment of COVID-19. It's all new uses of old molecules. Old is not patentable. Discovery is not patentable. So the same laws that allows monopolies allows not granting patents. The same laws that allow monopolies allows the government, even when a patent is legitimate, it is new, it is inventive or whatever, the country has the right to suspend patent protection to issue compulsory and government use licenses. And more than that, and something that we had not used until now, because we have not been facing such crisis now, in the TRIPS agreement, there are security exceptions that allow countries to take any action. And it's really any action which is considered necessary for the protection of the essential security interest. And this is a security issue, and I think we need to do that. So I think to conclude, this is my last slide, as a community members, as countries, and we need to push our countries, and as international institutions dealing with public health, like Unitaid, like WHO, etc., we must advocate for the urgent implementation of the TRIPS flexibilities. First, to remove IP barrier, whenever there is these barriers. Second, to promote local production everywhere it is possible. If there is one lesson we learned from this COVID pandemic, it's too dangerous to put a production in one country. We have seen seizure of products from a country to country. We have seen control of API. We have seen a lot of things, and it's super important. We have seen it, even simple thing is the mask. It was just ridiculous that the entire planet buy their mask from China. And when there was a problem in China because they needed the mask, because there was a shutdown or whatever, nobody had a mask. So it is super dangerous, and we need to promote local production of everything, including everything, I would say. Medicines, food, or whatever, but when it comes to medicine, it's super important. And I think also to improve the quality of voluntary licenses, because to negotiate voluntary licenses, you need to have a leverage for negotiation, and I think the pressure of the government. And this would help to ensure access for all, for everybody. And I remind here our position. It's not anymore an issue of developing countries or poor countries or whatever. It's an issue of everybody, rich and poor, everybody at the same level. And thank you.
Thank you, Mellouk. Thank you very much, Othoman. I know there's a very short time and a lot to say, and we want to be able to get to the discussions, but thank you very much for that really great and passionate intervention. We would like to bring on our last three speakers and three in the area of community-led monitoring. We've heard a lot about supply, forecasting, pricing, but what is the situation on the ground with communities, and how can communities monitor and hold the system accountable to ensuring that the quality of services are not impacted as severely, or at least there are improvements in the healthcare system for access to services. So bring on board Lotti to give us a 5-minute intervention.
Thanks, Wame. So just quickly going into what we've been doing with the Untitled project, which is a community-led clinic monitoring project in South Africa, being run by the Treatment Action Campaign and other PLHIV sector organizations with support from HealthGap and Georgetown and UMFA. And we basically had to halt our physical monitoring when COVID started coming into South Africa. And we switched to a model of virtual monitoring instead. So where we had normally been going into clinics to carry out interviews with facility managers, to carry out numerous interviews with patients and people living with HIV, instead we've switched that to virtually. So through phone calls to facility managers where we have existing relationships, and we've already built existing relationships to try and find out what the challenges are. And also to the networks of people that we already know who are collecting medicines at those sites to try and understand what the patient perspective is at those sites. So that's what we've kind of done, continuing the existing community-led monitoring project. But we also built some new surveys and new monitoring tools in order to capture what are the challenges people living with HIV are facing because of COVID. So we launched this survey on this slide. The PLHIV sector launched the survey, which is basically trying to find out what are the extra challenges of finding now because of COVID-19. Can you access the site? Can you access your normal HIV and TB services? Can you collect the right amount of medicine? And we've launched that with options for people to send a please call me, which is a free way that you can send a message to someone, and then someone will call you back and do the survey. So we didn't want to exclude people who don't have access to data to fill out the survey online. And we also started like a SNAP survey just to find out how long supply of ARVs people were collecting at medicine, just to find out if people were getting a longer supply. That's what we've been pushing for, especially in light of COVID, in order to collect more medicines so that you don't have to return to the facility as often. What we basically found out and continue to find out is that it's almost a disaster on the ground. The SNAP survey showed us 400 people responded that during lockdown, they have been receiving, the majority, about 63%, have been receiving 2 months supply of medicine, but 27% of people are receiving less than 2 months supply. 1 month, we saw 3 weeks, 2 weeks, 1 week supply of ARVs, which means they're having to return to the site again and again. We've been pushing for 3 months for a long time, let alone 6 months. and less than 10% of people are receiving those amounts of medicine. The kind of ad hoc monitoring at site level, we're just finding that HIV and TB services are not really being provided. There's no viral load testing, there's no HIV counseling and testing, the TB testing is reduced by half, and there's no kind of standard operating procedures for what's happening when someone tests positive for COVID-19. So if a healthcare worker or a patient who's used the site test positive, they just shut the site down. And there's no explanation of where patients need to go instead of using that site. There's nothing posted to the gate. The clinic's just closed and people don't know what to do. Even this morning, I got sent pictures from one clinic where there's a huge queue of people waiting to collect their medicines, and 5 people's books are being taken in at a time to bring out their medicines to them. But obviously, there's no social distancing measures in place at that site as people are waiting. So we've had about 400 responses to the PLHIV sector survey so far, and there's just a number of worrying indicators that are coming up. 20% of adherence clubs are not functioning, 13% of facilities are having a stock out at the minute, 20% of people just can't get to the clinic because there's no transport available, 34% of people are saying that there's no water or soap available at clinics, 15% say that there's zero infection control or COVID-19 measures in place at all to reduce infection. And a worrying 30% of people are too scared to go back to the clinic now because they're worried about being shouted at because they've missed an appointment. So the community-led monitoring is really important to highlight some of the challenges that mean that people just aren't getting what they need to be getting. The other challenge that we're facing is the rollout of TLD in the country. Now, because they want to switch people to TLD because there's longer supplies, people are being switched, but there's no counseling or education for switching. So there's a lot of reports from PLHIV fearful for being switched, not understanding the side effects that are going to happen, not really understanding the treatment, and then just living in fear about not knowing what's going to happen. And so we're having regular meetings with the Department of Health and the PEPFAR teams and others in order to try and showcase what these challenges are so that they can address them as quick as possible, because on the ground, it's not looking a rosy picture for people living with HIV and TB. Thanks.
Thank you very much, Lotti. Thanks for painting that picture, especially from the recipients of care point of view. Over to Olive, who's going to give us the context of looking at communities strengthening and also engagement in the context of the Global Fund frameworks. So over to you, Olive.
Thank you so much, Mwame. We all know that the one—
Sorry, Olive, do you have your camera possible?
Okay, thank you. There you are.
See, we must see your beautiful face. Come on.
Thank you. Thank you so much. What I was saying is that we all know that the one who wears the shoe is the one who knows what pinches most. And it is with that background that EANNASO, really took on the element of community engagement. If we can go to the next slide, please. So whatever we do, and I think in most of our organizations, whatever we are doing in terms of making sure that the space and the voice of the community is heard, the very biggest thing that we should think about is engaging communities, engaging civil society. Let's move to the next slide, please. So with that, the Global Fund also heard our plea of making sure that civil society and communities have a space and can talk. And then they came up with what is called the Community Rights and Gender Strategic Initiative. For me, I'm talking about what is currently happening now. There are 3 phases, which is short-term, the long-term is the second, and the third is the regional platform. So EANNASO, next slide, please. EANNASO, together with other 6 organizations, coordinates the communication and coordination platforms. And there are 6. 3 are based in Africa, which is the Anglophone, Francophone, and MENA platforms, which are basically looking at how civil society can better engage, but also looking at where can we get technical support, which is short-term, but also for the community organizations and networks, a longer-term type of technical support. So next slide, please. We all know that the Global Fund, I've taken this slide from the Global Fund. We all know that the Global Fund believes in country dialogue. And this has helped us coming from civil society and us coming from communities to be able to engage in processes. And we believe that this is able because that is where we can voice our concerns around community, human rights, and gender. So it takes a 360 degrees approach from the onset when we develop our national strategic plans up to the point where we are implementing and monitoring our projects or monitoring the grants that are being implemented, whether they are from the Global Fund or from other partners. What is key is to ensure that communities' voices are always included. So I wanted, if we can go to the next slide, please. I wanted us to talk, basically, I wanted to hone into this presentation. There are 3 areas where we have seen that civil society and communities can engage when it comes to community-based monitoring. When I talk about community-based monitoring, I believe that it should be based within the communities, but it should also be led by the communities. This is very key and crucial because otherwise we find our voices are, not what they should be. So there are 3 areas that I wanted to talk about. The first one is around the CCMs. CCMs are a key element where decisions are being made. And if we are collecting information, that can be evidence or data that is used by the communities to be able to influence decisions at the CCM level. But secondly is at the implementation where we see that country grants are being implemented by the PRs. And at times there are issues that relate to human rights, issues that I think someone talked about access to medication and all the other commodities that we're talking about. So those are also the areas where communities are able to identify and see that this is, we're lacking this area, we're lacking in that area, and pinpoint it out, such that those issues can be solved. Those issues can be solved at the community level, at the national level, even at the sub-national levels. The other area that I wanted to talk about is the inclusion of the community-led monitoring or community monitoring processes. If we are to be able to implement community-based monitoring systems, we should ensure that these are funded, because the assumption is that civil society already have systems that are functioning. But no one talks about how are these systems funded. So for us, we saw that this, the fund requests development process is an area that should ensure that our priorities, including community monitoring, to be included within the country grants. So I just wanted to quickly just highlight some of the systems that are currently happening within EANNASO, being the Anglophone Africa platform. We have the Stop TB Partnership, which is a Stop TB Partnership-led mobile app, which is called One Impact. We have contextualized it specifically for Tanzania, so it's called TB Janja. It's a mobile app. Also, as EANNASO, we developed together with the TB in the mining sector for Southern Africa for both phase 1 and phase 2, some toolkits that document human rights and gender abuses, but also support communities to be able to advocate for key issues. And so those are the 2 tools that I have mentioned there, the Civil Society Community Video Toolkit, but also Spot TB. These are around TB. And currently, we are developing a community-based monitoring guidance tool for civil society and community groups. This is on now what is the process? How can you integrate community-based monitoring into Global Fund processes, especially the fund request process? So it takes you step by step in terms of how to include them within the modules, but it also talks about what should you look out in terms of the cost factors, how to implement it. So it's a very critical document. It should be coming out shortly by next week. We know that we are a bit late, but we are targeting the countries that are going into grant making and those that will be also going for phase, the 3rd window of submission of fund requests. The next document is a compendium of tools which facilitate civil society and community engagement. This is also underway, almost about to be finalized, but critical in this document, it talks about all the three areas: implementation, what are some of the tools we should be looking at, coordination of civil society, what are some of the tools we should be using. However, what I wanted to talk about is the integration of CBM decision making, specifically within the CCMs. It's a process which we piloted in Uganda. It talks about from the development of the community-based monitoring itself to the point of gathering information, but then how can it be integrated within the CCMs and how civil society can be coordinated to take that information into the CCMs. This is also a document that you should be looking out for, coming out shortly in the next 2 weeks. In addition, what we have also been doing is there's been a question, especially for civil society and communities, that we want to do community-based monitoring, but we don't know how to do it. So what we thought together with a team is to map out existing CBM systems in 6 countries. And it shows, how our colleagues are doing, the actual, how are they implementing, how information is being utilized such that these are examples that can be taken to develop systems at national level. So with that, I just wanted to say thank you so much. These are some of the things that EANNASO is doing. Asanteni sana.
Thank you very much, Olive. Thank you very, very much for that. I would like to invite Alain to give us the last presentation, and this is really around the tools that can help us do this community-led monitoring. Please prepare your questions, put it into the Q&A. After Alain, we'll open it up for the panelists, a round of discussions with the panelists, and then with everybody based on your Q&As. Thank you, Alain.
Thank you very much, Wami. Good afternoon, everyone, again. I want to take you through what is our foundation in terms of community-led monitoring and what should be used to guide us to understand the impact of COVID-19 currently. I will use the 4 quadrants: education, evidence, advocacy, and engagement, which are the foundation. Basically, we need to bring information to the communities. We need to gather information as evidence through data collection, and you need to provide opportunity for advocacy and then engage in key decision makers for advocacy for change. So this is what is happening in, I would say, in a normal context, what we do using HIV as an entry point. But in the context of COVID-19, what should be done and what have we done so far? First, we try to look at what was the impact on COVID-19 in terms of people and community accessing information. What are the key data we can use to understand really the impact of COVID-19 on people accessing HIV services, treatment, stockout, and how can we use it as an advocacy? But what is more important for us, and it's in the next slide, we use the 5 A's analytical framework. And this is important for us to understand in the context of COVID-19. We will look at the availability of services, usual services like HIV, TB screening, viral testing. Are they still available in the context of COVID-19? Because we know that COVID-19 has impacted the availability of services. So when we look at this, even taking into consideration the lockdowns, it was clear to us that very few people have access to these services. There was a risk of interruption of HIV treatment, but also at the same time, people accessing normal services. Accessibility, I was happy to hear the colleague talking about the testing. One of the key one of the key information which is important for the community. Are we able to access testing in relation to COVID-19? And today we cannot say yes, because even if in some countries these have been made available, but there are not enough tests for everybody. I can take an example of one country, which I don't want to name. There was very few testing and promotion of testing. So people gathered to the testing centers, and what was happening is no respect for social distancing. So when you bring people to testing and you don't take into consideration for them the social distancing, you expose them at the risk of infection of COVID-19. So this is what is important to look. How many testing centers are available? And also taking into consideration the distance people have to travel to make sure that they are able to get the services. In terms of acceptability, we know that in regard to COVID-19, there have been an increase of stigma and discrimination. And the services which have been interrupted for HIV and for key population have also impacted on the accessibility of services, because there was a fear of community to access these services because of high stigma and discrimination, no services specific for key population, and no services specific for a number of communities. The affordability, I'm not going to talk about it because we are still trying to understand what will be the cost of the testing, and if vaccines come out, how much it's going to cost, and the appropriateness of the services we need to look at. Then we need to look at what are the public health services. Are they meeting the usual standards? And this is quite important because with the lockdowns, you have people with concern or fear and fear to be exposed to the COVID-19. They stayed at home, and even with the information provided on how to prevent, and ITPC, we were able to share our guideline on what people need to know about COVID-19. Despite all this information, it was still a challenge for people to access to the services, making sure that they are not taking a risk. So this is what needs to be looked at in terms of community-led monitoring. The 5 A's remain quite critical, but the challenge we will have, and this is how we need to make sure that we are able to adjust ourselves to the COVID-19, and this is, we have already started that. Usually all this information, whether they are quantitative or qualitative, are taken through data collection. It means that people are in direct contact with the community, with the client. So now, how are we going to collect that? And this is bringing the digital tools, the technical, the IT services. So using Survey Gizmo, SurveyMonkey, or using WhatsApp or telephone to conduct, for example, a focus group with a number of people, but also making sure that at the health facility, you are able to respect the social distance for for data collection, but also to interview people. And this is going to cost a lot. So, and reflection based on what is happening on the ground, it means that this is where we need to invest to make sure that people have access to the information. It means people are very well educated around the COVID-19, but at the same time, people can still have the information in relation to the HIV treatment, to the TB screening, and to the viral load testing. And accessibility, we need to make sure that we are able, the country are able to provide the adequate centers to the community, and people won't have to travel long distance because it could create a barrier for access to treatment and access to information, access to testing. I will say that the vaccine should be free for all, but also testing should be accessible and affordable to people. So service needs to be tailored and service needs to be client-centered. One last thing I would like to say, a recent survey done in Western Central Africa in partnership with UNAID has shown that there were three major concerns from people living with HIV/AIDS in regard to COVID-19. First, people were looking for having the right information, because they say that having the right information will help them to behave, to be a leader in their community and to share the information among themselves. Secondly, people have concern about the access to treatment, especially in regard to ARV treatment. And because there was fear of stockouts, and people were not sure that there will be a continuity of the services. And lastly, and I think Solange touched it at the introduction, there is a need for food supply. So because of the lockdown, this is affecting seriously the health of the community in relation to the access to services. So this is what I want to share. In conclusion, the four quadrants remain the key: education, to provide information to community, evidence, to collect the right information, and analysis, collecting, crossing them, qualitative and quantitative, advocacy, to provide the opportunity and resources to community, and engage with decision maker to influence the change, the advocacy for change. All this using the 5 A's framework analysis. Thank you very much.
Thank you very much, Alain, and thank you very much to your panelists. I'll now like to hand it over to Solange, who's going to co-chair with me the discussion from the panelists and also from you, the participants. Solange?
Right here. Hi, everybody. If you could turn on when you feel comfortable, you're as a panelist, your video, that would be really helpful so people can now look at your faces. I think, thank you, first of all, for everyone for presenting, and it almost feels like a lifetime ago that Lara spoke, but we started off with testing and we went through a lot of the discussions or issues around access and pricing and what that space looks like. And I think many people, if they were looking at the topic for today and the roundtable, which is about, you know, pricing, testing, and community-led monitoring, you wonder, well, how are these things even related? And did ITPC just put 3 things together that because they didn't want to do 3 different roundtables? And so I want to actually pose that question to you all as panelists. And I'm asking for a friend because, you know, naively, I think many people don't think that these things are related. Maybe putting it simply, you know, what do people have to do with pricing? So anybody can take that. And we're talking about medicine, we're talking about, yes, we're in the COVID space, but everyone here has a wealth of experience from HIV, TB, hepatitis. We have people who look at literal pricing, we have people who look at the market, you think about volumes. What do people have to do with pricing and why do we care? Andrew looks like he's ready to go. Go ahead.
I think people have a lot to do with pricing when they can't get the medicine. I think this is the acid test, and we've seen this with lots of other diseases. A lot of people don't mind about pricing if it's organized by the government and the medicine's in the pharmacy, but if they can see a medicine other people are receiving and benefiting from in other countries, and they simply can't get it, and they hear that the price is thousands of dollars in their country and a few dollars in other countries, you've got a huge political issue. You think about all the access issues we've had with HIV and hepatitis over the last few years, and you think about all of that focused on coronavirus. Imagine we had a treatment that improved survival and you could not get it in Brazil or the United States or Morocco or anywhere because it was too expensive. That's when it matters to individuals, and they will, I mean, I think we can see a potential for a huge outcry if the prices are too high.
Yeah, Lara, others?
Yeah.
So Lara and then Othoman.
I think people are incredibly critical for this, especially coming from the COVID side of things. One of the biggest constraints that we have, and it currently exists mostly with diagnostics and PPE, the commodities we need right now, is the lack of access. And so, of course, having better prices would be ideal. But at this stage too, the amount of access that countries in low and middle income settings have compared to those in high income settings, or even, you know, not even all high income settings, but really high market settings, the equitable proportion of the tests that are available is astronomically different. And, you know, I think we can't necessarily do that alone, but some of these conversations with suppliers and others, similar to sort of what we did in the HIV days in the beginning, to try and increase some of that access. And again, it goes across commodities, I think, and will become a pretty significant issue, as Andrew mentions, around the drugs and the vaccines once they become available, to ensure that there's some equity in distribution, that it's not just, you know, certain countries that get the first lots of any of those drugs or any of those vaccines, but there's some sort of an allocation, a fair allocation process that can happen. Ideally, we could also be talking about prices as well. At this point, though, it is a supplier market, but just, you know, the access issues, I think, are the most critical right now.
Lots to say, lots to follow up on. Othoman and then Vincent, do I see you? Okay.
Yeah, I think it's pricing is super important, because for the moment, maybe in many countries, it's mainly a government-led response with free whatever services you have at the country level. But it is definitely clear that this will last longer, that we may have other crises coming. And it is not sustainable to have a government fully funded response or whatever. And to some extent in some countries, and especially in countries like mine, Morocco, where not everybody has a social security, health insurance or whatever, to some extent this question will happen. And we will need to raise question is we're not anymore in a kind of only government fully response, and we may look at in-pocket expenses from people, reimbursement schemes, the role of third payers and all these kind of things, and it is super important. And what is disappointing, we had a World COVID Cab yesterday with Cepheid, who is one of the lead diagnostic producers today, and they are still in the old thing, you know, a kind of, oh, we have a $20 for price for lower income, middle income countries, $40 for high income. They consider Greece and Spain just like high income countries. It costs 2 times the price of TB tests, but at the same time, from the technology perspective, there is nothing that can justify why it would be 2 times higher than TB. Maybe what's inside the cartridge is different, but at the same time, it's the same technology, etc. So people are still coming with the old schemes of World Bank classification to decide who should get this price or the other price, etc. It's not anymore about the World Bank classification, about nobody can bear these prices. And I think we need, it's super important, because this is what will make countries put in place this thing instead of that thing or whatever. And really it is an exceptional situation, and we need exceptional measures. And as I said in my slide, if we are just coming with old models that have failed, if only it worked for other things, we will say, okay, let's trust them, it may work. It's not working. We need something. And the key thing is really the price.
Interesting. I want to come back to you on that, and then I'll do this round, and then I'll pass to Wame. Vincent?
Thanks. Building on the previous point, I think people have to do with pricing, and this was demonstrated, you know, with so many decades and work and efforts in HIV, and the same will be true for COVID. And beyond pricing, it's equitable access. Pricing being one factor of access, but equitable access has many components. Right now, if you look at COVID diagnostics, before you talk about price, it's about having the right test and having the right volumes of tests. And until you have that, solving the price issue will not be sufficient. And I wanted to echo also what Othoman was just saying. I think equitable access is taking a completely new dimension in the context of COVID. It's no longer about some of the lower middle income countries getting access to treatments under specific conditions. Right now we're hearing the president of Costa Rica calling for voluntary pooling of knowledge. We're hearing the Prime Minister of France calling for equitable access for all the products in vaccines, treatment, and diagnostics in COVID. So we have to rethink, the way equitable access is looked at. Of course, there's a lot of mechanisms and ways of working that we've learned from the past and that would be extremely relevant. I think some of you mentioned the medicines patent pool, which is something that we're, as Unitaid, still funding, and that has been around for 10 years. The MPP is working on COVID right now and looking at ways to support this work. But it's not just about treatments, it's also about diagnostics, it's also about vaccines and a number of other issues that will need to be tackled as well.
Yeah, so we won't be ITPC if we didn't push on this a little bit more, and then we can go forward. So the issue is access. We're looking at testing right now, and the issue is access to that testing. Everybody has they have problems with access. Price is one factor, and equitable, allocation is another way to think of it. What are other factors that are preventing everyone that needs a test from getting a test? And it doesn't seem to me that it's only or mainly about price. It may have to do with geopolitics, companies not allocating to low and middle income countries. And I wanted you to tell us, what can communities or civil society or people do to push and change this? And I cannot be punting questions only to Othoman because this is too ITPC. Let's start with Lara, we'll go to Andrew, and then I'll get to you, Othoman. And then
So again, I think in this initial phase, my sense is there's a fair bit of funding and a fair bit of excitement to provide support to countries on the testing space. I think we're a little bit less worried about the $20 Cepheid price at this stage, and I'm not all sure who's on the line right now, but at WHO's standpoint, we're being very open and very transparent. For us, the biggest thing is, whether it's Cepheid or Abbott or Roche or any of the other suppliers that are already being, the automated suppliers that are already in use, the number of tests that we have access to within the consortium for low and middle income countries, and that includes some also high income, small island developing states as well that also have poor access to testing, is incredibly small compared to the bucket that is being kept by those companies for the high income settings. So Cepheid, for example, we only have access in low and middle income countries to 82,000 tests on Cepheid. You imagine that, we would be thrilled to pay to get access to 500,000 still at $20. Again, ideally a lower price would be better, but it's really about this sparsity of the commodity itself going to these settings. And so when you look at, if we actually did an equitable allocation across all countries, so that's 190 plus countries, as well as some of the sort of territories, et cetera, the proportion of tests that are going to weaker market, I suppose, if you would say, countries, is incredibly small compared to what their equitable allocation should be. And for us, I think that is the biggest item over price, et cetera. It's getting those suppliers to open up and allow for more tests to be available to low middle income countries. Because again, I think the interest, the funding is there for now at least. And if we sort of push and demand on a lower price, it's a little bit more challenging to convince a Cepheid to give us a $10 price tag when they're selling it for $60+ in high income settings. And, I think that business first approach is expected from such suppliers, but I think being able to push, and at least initially, we would really probably seek your support in trying to work together to gain that greater access. And then eventually, hopefully, we can start talking about lower prices as well.
Thanks, Lara. Agreed. Andrew, did you want to, or should I go?
Yeah, I mean, two things really. I think it's important at a community level to show how people are suffering because they're not being tested, to have lots of case studies, population level studies. And the second thing is, I think everybody would agree that the UNAIDS 90-90-90 targets they've really concentrated governments on what they need to do. And if you had some target that 90% of people who have coronavirus symptoms should be tested in every country, and you could track the percentage country by country. I'm sorry, but in the UK, it's going to be something really embarrassing. I don't want to say that I'm working from a country which has we're probably one of the worst in the world, but we're nowhere near 90%. I mean, it's hopeless. But just have some barometer. You can have a world map, percentage of people who are symptomatic who are tested, and I think it would give people something to aim for. At the moment, like you say, Lara, there are just all sorts of stories of people not getting the right access, but it's somehow quantifying it makes the governments more accountable.
Thanks, Andrew. Agree. Okay, Othoman, then Vincent, and then Wame will switch us to another question.
No, I totally agree with Vincent. The price is not the only issue. I think the biggest issue that we have now in terms of testing is really the capacity to supply. We don't have enough tests, and we have seen it clearly from the CAB meeting that we had yesterday from CFID, that they cannot supply the entire world. So we need to see what is the capacity of the others, the competitors, Roche or Abbott. But even if we have a cheap price, if we don't have the enough quantities, who's going to be served first? I don't know. We have seen threats of some governments and powerful people in the world saying, my country first, if you don't give me, I will do for you that or that. So even if the price is cheap, if the quantities are not enough, where probably there will be, we struggled yesterday to have a kind of indication what will be the supply for middle-income countries and upper-income countries.
Oh, sorry, nobody knows what you mean by yesterday, because...
No, we had a World CAB yesterday with a group of community people, 30 people from all over the world discussing with CFAID about diagnostics, etc. And they were not able to come up with us for a projection of either percentage, which will be allocated to low and middle-income countries or upper-income countries. They say that they are doing on a weekly basis, and we have no clue how they decide who should be supplied first. So I think this is super important. Where I don't agree with Vincent is that, yes, we need pooling of technologies, IP, know-how, and everything. I don't believe that the voluntary principle will work. I think it should be a compulsory principle, and we have all the legal tools nationally and internationally that allows countries to request such compulsory pooling. If this leads us to some kind of voluntary agreements that is a kind of win-win and that works or whatever, it is good. But I think basing this from the principle, from the beginning on the principle of voluntary will or whatever, I don't think it's gonna work. And I think this is, I may understand some institution can, to some extent, it's very hard to push for compulsory mechanisms or whatever. But I think for government and for civil society, we should push for a compulsory sharing of this kind of knowledge. If it leads to any kind of voluntary licenses, I'm fine to take any voluntary agreements that are fine or that can help access. Not to say for the entire planet, but at least for some, it's done, and then we can find solutions for the others. But it's really important. We have tools, and we should just use them. And as I said in my slide, it's a kind of rights-based approach. The companies use their rights. We invested in whatever, we have a right. And we have rights that are written at the same time that say that countries can suspend patents and whatever protection, and we have different tools, and this should be used. And this is the only way that we can have a better deal. But if we keep it completely voluntary between those who will never go to the voluntary, between those who will come with a kind of bad faith and saying, you know, I'm going to give this and not that, etc. It's going to take time, and we are not going to have a solution that works for everybody.
Thanks, Othoman. Vincent?
Thanks, Solange. I wanted to come back to your question, what can communities do to support? I think one thing that would be really helpful is to support making the case for testing, because I'm seeing, decision makers when thinking about COVID response and COVID tools, will think first about vaccines, and this is what everyone, of course, would like to have. Second, about treatment, and only third, about testing. And making the case for testing is difficult. I'll be very honest. It's difficult to explain what's the value of testing, especially when you don't have a treatment yet. And even without a treatment, testing has a lot of value, but that needs to be explained, and we need to make the case for it. So I would pledge, for that support from communities to make the case for testing in general.
In the case of COVID, is testing prevention as well?
It should.
In HIV, it's treatment is prevention. In the case of COVID, is testing prevention.
It should be.
Yeah, I don't know, just
Depends
thinking
how
about that.
quickly your results come back, Solange.
Well, if you actually get a result, well, that's my favorite topic.
If it takes 2 weeks to get your result, then is it a useful intervention for contact tracing?
Good question. Wame, over to you.
Yeah. No, and I think that really brings us back to the question. Thanks for that, Vincent, because one of the things that we've been toying with is what can communities monitor? So Lotti, Olive, and Alain, what are your thoughts in terms of, from the community perspective, what are the things that we should pay attention to? We heard from Vincent saying, look at the issues around testing, quantification, scale up of testing. What are your thoughts in terms of the community's role in all of the COVID response?
Can I go first?
Sure.
Thank you, Ame. On my side, I feel like the very first thing is human rights. We have seen human rights and gender violations. We have seen in most of the countries, especially those that had partial or full lockdown, consideration was not made to how will people survive if we close up. No transport, no public transport, no courts, no shops, essential. Yet there were, the communities were not provided with support. I'll give an example of sex workers. We all know that sex workers make a living from the business, and if you close everything, it means that the business is not going to happen as it's supposed to. Therefore, we are denying not only the individual, but also the family and the community that is supported by closing up fully like that. So no one will be able to know if such things really are happening if there is no community monitoring. Issues around gender-based violence, who is doing what, the police brutality, if we don't come up, document evidence, because one of the other issues has been that as civil society, as communities, we've been told that, no, you talk, but you don't have evidence, you don't have data. So right now, community monitoring is a way of us being able to look at what is supposed to happen, that discourages stigma, that also discourages discrimination, such that everyone is able to access accordingly and without any limitations or barriers. So for me, human rights and gender-based violations is one thing that should be monitored. Yeah.
Thank you, Olive, for that. And if I can probe further, Alain and Lotti, and really look at what is the best way to collect that information, right? We have movement restrictions in many countries, inability to access the recipients of care in the same way we used to be able to before. What is the best way to get community monitoring going in countries? How can we collect that information safely?
Yeah, thank you very much, Wami. I think what is critical is for us to be very innovative, because if we have to respect the social distance, but also to invest in prevention. We need to take this into consideration. Therefore, it should be a combination of on-site data collection and using online data collection. When I say on-site data collection, it's because sometimes it's better that there is a face-to-face discussion with the patients so that the patient can fully express themselves. If we used to do a focus group discussion with 20 people or 30 people, we will have to organize a series of focus group discussion, because a focus group discussion are the space where community feel safe to express themselves and give the full of the maximum of their thoughts. So this is one thing. But if we are not able, and this is accessing a free space where we respect the social distance. And if we are not able to do that, we have to use the digital material. And what, like I said, for recently, the approach we used to assess the need of people living with HIV/AIDS in the context of COVID-19. It was through online, but because people didn't really understand the question, we have to use a telephone to explain for them to complete their response. So it should be, for me, it should be a combination of both, because one cannot exclude the others.
Thank you very much.
Can I come in? So I think from our perspective, the things that we've been monitoring has generally been around how PLHIV and people with TB are affected during this time. And some of the questions have been specific to COVID-19, like we've been asking around like income. How's your income shifted? Has it gone down? Have you got nothing now? Did you not have anything before, just to get a sense? And things like, how do you get to the, are you able to get to the site now? There's been lots of reports of, you know, people being turned back because of authorities turning them back, or being fined because they haven't had a permit to leave the house in order to go and collect their ARVs. And when you go and collect your ARVs, there's nothing actually written down with your appointment date. So there's no proof that's where you're going. So there's challenges like that. And then there's been like the specifics of, you know, can you get contraceptives during this time? Can you get PrEP? Can you get an HIV test? Can you get a viral load test? And like the answer has been no to a lot of those things. And then in terms of the how, it's really varied, and there's like different levels of positive response depending on like the platform. For us in South Africa, like people are not going to fill out an online, like the majority of people are not going to fill out an online survey themselves. So we had a system of like in every province, there's a number that you can send a please call me to, which is a free thing that anyone can do. And then someone will call you back in the local language and talk you through the survey. And that had like a bit more positive responses. But actually our SNAP survey was much easier because we did it via WhatsApp. So because we did it via WhatsApp, people were WhatsApping a lot of responses back, which was great for responses. We got 400 in 5 days, but it was terrible for me, who had to clean and compile the data that was coming in via WhatsApp into one set of data, which just took forever. Whereas like when it's online, it's much easier because it's a Google form and you've already got it cleaned-ish, and ready to utilize. And then we haven't had enough resources in terms of airtime and data in order to have enough people doing the calls to people we know who could respond on the survey in order to get the responses. We have had information coming in from 350 clinics, and I think that's important. Even if it's not a lot of people from all of those sites, that's useful information that's coming in from 350 sites that we then use to put pressure on PEPFAR, to put pressure on the government to try and fix those challenges. So for me, even if there's a little bit of data, it's useful to lead to the advocacy and sort of push through. And we already have our mechanisms for kind of rapid response with the Chitse project, where we send the data that we're collecting from the site. So that's how we've been also utilizing the things that we're collecting through the COVID specific time to try and fix some of the challenges.
All right. Thank you very much. Another question, and this comes from some of our participants around sharing some experiences in terms of the reactions from implementing partners, in particular government agencies, to the findings that we have on community-led monitoring. And this is really critical because we constantly hear this, you collecting information as a community to do what? To do the advocacy. So what has been the response? What has been the reaction? And how have the results, how do they see the results? Do they see it as fault finding, or do they see it from a negative perspective, or do they see it as something that's helpful? Lotti?
They find it helpful. I'm not sure about implementing partners, but I mind less about that. As opposed to the kind of CDC and USAID at the top who have the power to push the implementing partners to do what they should be doing. So for us, we are invited and sit within the Operation Putuma, which is the government's response to try and get to 1990, and we take the data that we collect alongside the data that PEPFAR collects, alongside the data that the department collects, and that is all fed into the Operation Putuma to try and shift what needs to happen at a site level. And we have different mechanisms for rapid response within PEPFAR. So we meet regularly with the CDC and USAID teams to be like, this is what's happening in these sites. But we also have like a rapid mechanism where we have a WhatsApp group just with the Department of Health technical team, and we have a WhatsApp group just with the PEPFAR, the USAID and CDC technical teams. And and the comrades who are collecting data on the ground, I know this is a bit pre-COVID, but just explaining. The comrades who are collecting information, if there's something that needs to be fixed that day, for instance, an implementing partner nurse is disclosing people's HIV status as we're in the facility now, or there's no fixed dose combination first-line ARVs in the site now, or people are being sent home with 5-day supply, then we immediately send that into the relevant WhatsApp group to be like, here's this site in this district, in this province, this is the challenge, go and do something about it right now. And that has also been a helpful, like, rapid response mechanism to get challenges fixed as they're going along. So yeah, on the majority, they want to hear what the challenges are so they can fix them quicker than writing media statements and doing advocacy that will make them look bad for the challenges that are on the ground.
Yeah, I think to add on what Lotti said, it depends on how you build your evidence, because what government will be looking for, and if they have been looking, when you show your result, they just try to see if what you say is based on evidence. And I think they found what we have shared with them regarding the need of PLHA very useful, because it helped them adjusted their policy and what the decision they were making in terms of dispatching center regarding the ARVs. Because of the COVID-19, there have been a number of dispatching centers across the country, in many countries, and the information was shared with the community for accessing accessing treatment. But in fact, it's not all these dispatching centers which were filled with ARVs, and there was a stock cut in some of them, and the government was not aware because they have a cut in the chain of communication. So they found it very useful because all we are presented was based on evidence with clear data from the community, but also from the health centers.
Yeah, I just wanted to also add that responses come differently. You know, there's certain things that communities can respond to directly based on the results from the reports. There are things that will happen even when the issues happen. You know, communities can quickly respond. We saw like colleagues in Uganda, where certain communities did not have commodities. Other people would get permits from the government and respond quickly. And that was because of a result of the reports that were coming out. For other issues, they had to go to the government to really, sit, dialogue, and inform. Not everything, governments are quite sly as well. So not everything they'll just accept, but you really have to have hard evidence, and you have to show that it's happening across the country. So yes, there are things that can be responded to at different levels.
Thank you, Olive. Solange?
Yeah, I want to keep bringing us back to how these things connect, because I think that it's often so very one is on this end and the other is on the other side. There's the price and the medicine and those other people who do that stuff, and then there's all of us in the real world and on the ground. And I think that point from Vincent and Othoman and Lara, everybody, about making it not just about vaccines first and treatment and then testing, but really trying to put the focus on the importance of testing and how to make the case for testing, and really being able to capture and document the experiences of people on the ground and how people are actually across the world as humans suffering, not just in poor countries or in rich countries or different colors or whatever you want to have, however you want to divide the world. So I'm just thinking now about, in terms of testing, and I guess also the medicines, are you seeing production or shortages, so like genuine ones at the manufacturer level for other diseases, like for HIV, TB, tests and medicines? Are we seeing that? And not just like from a community-led monitoring perspective where you can identify that there are shortages or there's stockouts in particular clinics, but at a national level? I know maybe there's a question from a community monitoring side, what's the community seeing? But what are we seeing from top down? Are we seeing shortages or manufacturers saying, I'm sorry, we can't do it all and we only have to do some as there's a shortage now, particularly in other diseases, huh? Lara?
Do you want me to jump in? Yeah, so I think, I know that we have seen this already for malaria rapid tests, that one of the suppliers has slowed down their production and indicated that they may not be supplying additional purchase orders, which is unfortunate to hear. And I think it's definitely a critical piece for us, and this is putting my HIV hat back on, that we want to really closely monitor. And I think, your support in the community as well, to be able to put sort of some of that pressure and the push for suppliers to continue to provide HIV, TB, malaria testing to countries, and then, potentially in the same quantities, or at least to fulfill the need that exists at the moment, will be really important. We're trying to do so within the negotiations and conversations from the WHO standpoint within the consortium. And we're looking to develop a group that's similar. I know it exists already on the drug side, to try and monitor this, particularly in the time of COVID, but potentially, thereafter as well, because this is a key part that I think we're a little bit nervous, especially since some of the suppliers are the same between HIV, TB, and COVID. Might we see some reductions in manufacturing capacity and production? Again, they've promised not to do that on the HIV and TB side, but I think, ideal to hold them accountable to that as well.
Andrew and then Osman. Sorry, I'm looking at the...
Yeah, so I mean, the supply chains for many different medicines have come under incredible strain. Firstly, because China shut down production for a few weeks in late January to early March, and then Indian formulation was disrupted as they went into lockdown, coupled with huge increases in demand. So even France was running short of key drugs used in intensive care like midazolam, different anesthetics, antibiotics. And then you've got this repurposing leading to problems for the people who originally took the drugs. So Kaletra was thought to work in January, February, and there was a moment when India had no more Kaletra. The whole country, there was no more Kaletra. Hydroxychloroquine the same. So you've got this perfect storm of restricted supply because of lockdown, coupled with massive increases in demand. And it's really something that needs to be monitored on a drug by drug basis. You've got this whole list of drugs used to treat coronavirus acutely, and then you've got these other drugs which are in development. And I mean, let's say sofosbuvir worked, or Truvada or something, you know, what would that mean for people with HIV or hepatitis C? So I think we've got to bear that in mind when we make these forecasts.
Thanks, Andrew. And maybe you can tie that to the question, often when you respond to the local production, how do we all of a sudden then just have local production, which clearly is necessary?
Yeah.
No, yeah, definitely. On the diagnostics, from the discussions we had yesterday from CIFE, they say that for the moment they are going to slow down TB tests because we are on the third year of the global fund cycle, and countries, because they didn't spend money, they are going to buy a lot of tests. So they discuss with the global fund, etc., and people are going, so they need to stop production for TB tests because it's complicated for them you cannot produce TB tests and next week COVID tests. It said that you need to clean the machines and do all the kind of stuff. So definitely there is a decrease probably on TB tests, at least confirmed from Cepheid, from other STI tests like gonorrhea or whatever. And the understanding is that because of the lockdown, people have less testing or less sexual relationships, so unlikely to do tests. I think the point Andrew is making, we need to make sure that the more we know about the COVID virus, it is a kind of systemic disease now. It's not only about a respiratory thing and your lungs or whatever, it affects the whole system. So we may need, and we will need, a whole range of medicines that are not under the radar today because everybody is looking after the cure and remdesivir and sofosbuvir or whatever. So all these medicines are needed. We had 2 or 3 days ago with Andrew as well, a meeting with generic manufacturers from Morocco, from Algeria, from Brazil, Argentina, etc. All of them have stated that there is a high increase of costs of API on simple molecules like antibiotics, like azithromycin, and we have seen even prices of paracetamol or whatever going up. So it's not really, I think it's an issue of access to medicine, and we should not limit it to an issue of COVID drugs or whatever. We need to know what will happen tomorrow for tenofovir and emtricitabine if it becomes, there are clinical trials today in Spain, and if these reveal to be effective, what will be the impact on people living with HIV, on PrEP? Same thing for sofosbuvir and dacladacivir. It's 2 weeks treatment for COVID. Will everybody shift to COVID? What will happen to people living with hepatitis C? So I think it's a whole thing of access to medicine, and we should not limit it really to 2 or 3 drugs to COVID cure. And it really goes beyond. And this is where local production is super important. We have seen it's just too risky, it's tricky. All countries have the right to seize and to block anything produced at their country level or transiting in their country level for public health emergency or whatever. What will happen to all these medicines produced if tomorrow India says, well, India first and the rest of the world after? What will happen? All these medicines coming from India to Morocco, they don't come straight from Morocco to India. They go to Amsterdam and then they go back from Amsterdam to Morocco. What happens if it is stopped in European level or whatever? So it's really a big issue. And it's really, if there is one lesson that we should learn from this COVID crisis, is that self-sufficiency in terms of food, in terms of medicines, in terms of whatever, is super important. And we cannot give one country in the world, China, even the issue of most of API is coming today from China. I think India are trying to solve this problem now and to get some kind of self-sufficiency in terms of producing API, but it should not happen at India level as well, because just replacing in China by India. And it's really an issue that should be now discussed at every country level, how prepared we are to address this kind of problems that will very likely happen very often.
Seems like we're not too well prepared. Does anyone else from the panel want to respond? If not, I'm going to hand over to Wame to ask a question on financing. Then I'll ask one more question and we'll wrap up. Believe it or not, we only have 10 more minutes. And we've tried to pick the questions from the Q&A integrated into the conversations without having to type answers. Wame?
So one of the questions that a participant asked before she unfortunately had to leave was around the financing. Many donors, not just Global Fund, have offered the ability to reallocate the additional funds towards supporting COVID response from communities. But there is lack of transparency in terms of where the money has gone. So hearing from some of the panelists, are partners documenting whether the money is actually really reaching communities or the need on the ground?
You might want to address that to somebody specific.
Yeah, maybe Olive.
Thank you so much for the question, Wame. Currently, we see that there is a lot of funding that is coming in terms of COVID response. And unfortunately, most of these task teams, which are committees, are also being led by governments. And there's not been a lot of engagement of civil society in these task teams, COVID response task teams at country level. And because COVID also came in as as an emergency, no one was really foreseeing that. So currently, I have not, the people are discussing, but I've not seen any community-based, community-led monitoring, which is documenting exactly how the funding is being utilized. In most of the countries and communities that I've been talking to, there's not that transparency, and therefore there's a need for us to engage right now. And that's why the engagement process, I like what Global Fund is doing. They are, they've provided 2 levels of funding. One is from the flexibilities from the previous grant, which is the current grant right now. So they're providing 10% from savings, but also from reprogramming. But then secondly, they are also providing funding from the 10% of the current, which is the 2021-2023 grant, also where civil society can engage in terms of development of priorities. So it also, what matters is the transparent way of developing the funding requests, but because if that is not transparent, it becomes challenging for communities to get data, because government will most of the times hide how they are using. So it is key. I've not personally seen a monitoring tool, but I know discussions are happening at country level. Thank you.
Thank you, Olive. Anyone else wants to?
Okay, so we can't let Lara leave without us asking this basic question. So the type of test that's being used across the globe for COVID-19, across the world now, tell us about that test. What kind of test is it? And could you test negative and still be infectious?
Good question. So the test that is typically being used right now that we recommend to use is one that specifically detects the virus itself. The one that we also often use in HIV and malaria and others is one that will often detect and measure the immune response to a virus, and so the antibodies that you generate once you get infected. So for the molecular tests, the ones that actually measure the virus, whether you can still be infectious if you test negative is one question, and I'm not sure we entirely know that yet. But we do know that you can be infected, you can be sick, and potentially have a negative test. And there are a variety of reasons behind this, including maybe the test, no test is perfect. even, you know, in our other diseases that we focus on. There's also the potential that you could be sick and you just don't have a lot of virus in you, even though, you know, you are visibly sick, or you're perhaps asymptomatic, so you don't have any symptoms, but you are still infected. Whether those patients are also infectious, it sounds like it is the case, that you can have people who aren't visibly sick, who aren't coughing, etc., and are still able to infect other people. So this virus in particular is a little bit trickier than I think what we might normally expect from a number of other viruses. On the antibody side, you know, there's also those issues of you may not generate antibodies ever. You may generate some for a short period of time and then they go away. And whether or not those that, if you can generate them, actually mean that they'll prevent a second infection is something that we're still looking to understand. And unfortunately, the goalposts aren't quite set as we're hoping on the immunology and virology of this at this point.
Thanks, that's very helpful. We literally have 5 minutes. I don't know if anyone wants to add anything to that. But can I also just address this other question? How can we help countries forecast demand to inform the scale up of testing, treatment, and ultimately vaccines? What does that look like?
Are you asking me specifically, or
I'm asking anyone who wants to unmute and answer. Sure, you can go, and then Othoman. Vincent looks like he's thinking about the answer in his head.
Yeah, the forecasting piece is tricky, at least on the testing side, because it really depends on what you're looking to test for. Are you testing patients to understand if they're positive and whether they need clinical care? Are you testing people to understand, you know, what the surveillance or the prevalence in your country might be? And in that case, it would be sort of a different demand of volumes of testing. Are you trying to test people to see whether you can open up the economy, you know, reduce lockdowns, et cetera? So some of these different pieces are important. And even on the clinical side, you can also perhaps prioritize patients based on what your needs are. So, you know, there's often the mention of focusing on healthcare workers and making sure they get tested, focusing on those who are actively sick and need to be, you know, need to be referred to hospitals, et cetera. And so, you know, I think, but there is some value there in knowing what that total demand would be in perhaps a perfect world, you know, one in which you can provide complete access, and we, you know, one in which, of course, we understand a little bit better what the role of antibody-based tests are and how we can use them. But I think it would be valuable, and it's the conversation we continue to have, but it's one that probably needs to be done in a much more collective way.
Thank you. Vincent?
Yes, no, and indeed I mentioned, you know, a general number at the beginning of the discussion, you know,
Yes.
500 million tests per year. That's of course very rough, you know, and based on, you know, some assumptions around what Lara described, you know, different types of tests that you would use for different types of purposes across countries. This is something that we'll have to refine and that each country would have to, you know, to assess for its own needs. But in general, what we found helpful as a first approach is also to look at benchmarks across countries. There's been very different testing approach taken by different countries. And it's quite helpful to look at simple ratios like number of tests per 100,000 people, for instance, to see how a given testing strategy is positioned compared to some others, and to see if you're in the right ballpark or testing, you know, 10 times less or more than some other countries.
Thank you. Okay, so it sounds like it also has to do with what's your motivation. I mean, at the end of the day, why are you doing the testing? And therefore that will inform the rest of it all. And we know that those motivations are not always all pure and wonderful. And we have highlighted the access issue as not just a pricing issue at this point, but also about allocation, geopolitics, equitable access, and all of these things where communities and people have a role to play in shaping that response that we expect. I think if we had to make up a scenario in the world where we're like, yes, this was the only crazy time everybody should use a compulsory license because it's necessary, this is it. the one virus that is across the world, that doesn't care what color you are, what country you came from. So I think there's an interesting case, and of course the debate will be ongoing because there are many mechanisms and residual architecture that remains. We all kind of come from the old and expect to bring that to the new situation, but maybe there's some things that we have to leave behind and move forward in a new and constructive way. And I think COVID offers us that opportunity. Despite all of the stresses that we are facing, it is a chance to do it better. And that goes back to the whole question of, should we just return to normal? We can't wait to return to normal. Maybe normal and what we were doing before was actually piss poor. So we should do better. And on that, I have 7 seconds left. Thank you all very much for joining us. We really appreciate all of our panelists, all of the questions coming from the attendees. I know 2 hours out of your day is really, really tough. And I know Olive is going to go back and write all the Global Fund proposals, and Lara's going to fix all the testing, and Vincent's going to make sure that we afford them, and Othoman's going to get everyone a compulsory license, and Alain is going to make sure everyone has a good monitoring tool. And Lotti had to leave, and I think Andrew had to leave. But I just want to say thank you very much to everyone. Appreciate you.
Thank you so much.
Bye-bye. Bye.
Bye.
Bye.